Hi everyone, welcome to Women Empowerment Sharing Session. We hope that you enjoyed today's session with Dr. Natasha, who will be talking about psychiatry. Thank you, Dr. Natasha, for joining us today. Whenever you feel ready, please begin your presentation.
Hi, thanks for having me, guys. I'm Natasha. I am a PGY3 psychiatry resident in Texas, specifically Austin. And today I'm going to walk you guys through my journey, and then I'm going to go a little bit into the specialty. We'll do a quick case, and then we can open up the floor for questions. So that's kind of the agenda for today. The case does have a little bit of participation, so if you guys want to do that, that would be great. So I'll go ahead and get started. I'm going to share a little bit about how I got into medicine and then also how I picked psychiatry. So a little bit about my journey. I am an immigrant. So I immigrated here at a pretty early age, around 9, 10. And I went to middle school and high school in Texas. And then I went to Baylor University, that's also in Texas, and there I was pre-med. Originally a neuroscience major, switched to a biology major, and this shows a little bit about kind of like my journey into med school. I had to take the MCAT multiple times to score decently enough. I did go directly. I went straight from my senior year of Baylor to med school. And I really wanted to stay in Texas because I'd been there forever and my family was there. I got accepted into several out of school states, and I got into one in Texas, and that's the one I chose to go to. The med school I went to is called Texas College of Osteopathic Medicine. It is one of the only DO schools in Texas. And after doing 4 years there, started my residency at UT Dell Medical School in Austin. It's one of the newer med schools, and I'm currently a PGY3, so I'm sort of like 3/4 of the way there. And there's 4 years of psychiatry, so I'm in my third year. I'm gonna share a little bit more about kind of how I got there. Definitely went into undergrad knowing I wanted to do medicine, knowing I wanted to go to medical school. I was pretty focused on getting in throughout my 4 years. I was a biology major, like I said. I was a great text minor. I really wanted to have sort of like this application that showed my passion for medicine or wanting to go to med school, just because I knew that I wasn't a good test taker, and I knew that from like previous test taking, like the SAT and all that. And so I knew I had to sort of be very well-rounded and show my passion through other ways. So the few things that I really wanted to do was I wanted to be a tutor at the Paul Foster Success Center. So I taught like chemistry, biology there. I did work in a research lab. It was it's not for me for sure. It was bench research, but I did it for my honors thesis and ended up kind of publishing before coming in and applying. And then I really wanted to be in an organization, kind of like you guys are here. So I was in one of those. But at the same time, I really did try to enjoy undergrad. I was in competitive dance team as a sorority, and I did a lot of service events through my sorority. So definitely a balance here, which is kind of what I recommend for anyone who's going in, to be really focused, but also kind of have a plan as to how you're going to be a competitive applicant. So like I mentioned before, not all of us are great at test taking, and this was always like my weakest point. I kind of knew that going in. I knew that med school would be hard for me, and getting into med school would be hard for me, not because of my skills or my abilities or really like my knowledge, but just because I'm really bad at standardized tests, and they give me a lot of test anxiety. So I was kind of like prepared to do it. I did want to go directly. I think part of that was just the fact that I am an immigrant. My parents moved here, and I just felt like I didn't want to like have a lot of gap years, And I just kind of wanted to honor the fact that they came here for my education by not really having that space. But looking back, and looking back like 8 years ago, I realized that it really would have been okay for me to take a gap year. I think I put a lot of pressure on myself to not take one, and go directly. But I feel like looking back, it's totally okay to take some time to take the MCAT and really prepare for it. Because the way I did it is I did it 2 summers in a row. I scored decently on my first one, so I was like, I could apply with this, but I'm probably not gonna get schools in Texas. And then I tried to reschedule it, and I went into my second one, couldn't finish it, ran out of it before even finishing it, had to cancel it later. That's definitely a good thing about the MCAT. And then I took it the third time, and I got the same exact score that I got in my first one. And it was so incredibly discouraging. And I was like, why did I go through this whole thing? Actually applied with my first score. I didn't even use my third score at all, and got into a school in Texas. So, with that advice, don't lose hope. That's kind of like what my story is. You never know kind of what route you're going to end up still getting to your destination. A little bit about medical school. So kind of walking into this whole DO versus MD thing, really the two tracks have really merged well together at this point. There's not that much of a difference, except originally my whole thing was I really wanted to go to a DO school just because I liked the holistic property. I liked like the body-mind connection. I sort of liked that idea of the way they kind of explain it is the body has the ability to heal itself, and kind of treating with that notion. And so a little bit about med school in general, it's very test heavy. We had this joke in med school that you're basically like a professional test taker for 2 years, because the first 2 years are very non-clinical. So difficult through that. Nothing as challenging as like the MCAT. So I think it was still nothing in comparison to my attempt of trying to get in. And then really, really shine through my rotation years, just meeting people, being with people, helping people, being in person and really learning medicine. That's really what I enjoy. And so I think I shine there naturally. But also I was just so glad to finally be doing what all that sort of like road work was. And this is the part where I think, it's really interesting, where you're seeing different specialties and you're kind of like learning about different specialties. And most people come in thinking they're going to want to do something and do something completely different. And so I came in wanting to do pediatrics or family medicine. I quickly became interested in psychiatry, but I didn't think that it was going to be my end all be all. And then I did my rotation, and I really loved it. I'm going to share a little bit about that in a bit. And then was also considering OB because I really liked how it was surgical and clinical and clinic-based and not clinic. It was just a really good mix. And so I considered those kinds of things just because I wanted something that had a lot of continuity of care. So if you can look at the ones I was thinking of, that's something that was important to me. And so that's what I recommend for you guys, is kind of seeing like what kind of relationship do you want to have with your patient? Do you kind of want to treat and then send them out, or do you want to be in an operating room and see them once, or what kind of relationship do you want to build with your patients? Ultimately, I chose psych, and this is a little slide about why I love psychiatry. I could spend the entire day talking about how much I love psychiatry, but I kept it to these bullet points. I really enjoy my rotation. So if you guys get a chance to do like an inpatient, like sole psych hospital rotation, that's the best way to see what psychiatry really is. I loved that I got to spend as much time as I wanted with my patients. With psychiatry, no one's kind of like rushing you to get like a list of questions. It's more of a conversation, and I could spend 5 minutes in one room if I wanted and get what I needed, or I could spend 50 minutes in a room and really help someone have a breakthrough, even as a med student, and I love that. really like the neurobiology of mental health. I think it's really fascinating that you can kind of change dopaminergic or serotonergic receptors or the level of neurotransmitters to alter someone's behavior or mood. Like the idea of being able to help someone who has like a biological deficit of a neurotransmitter and altering that with either like medication or altering it with therapy is just so fascinating to me. So I kind of was already very fascinated with all that. I really wanted to specialize. So like I said, I was considering family medicine, but I realized quickly that I'm definitely a specialist. I like knowing a lot about one thing rather than knowing a broad amount of everything. I had my own experience with mental health that also played a big part of me choosing psychiatry. When I was struggling with like my MCAT, and like I told you guys, like I ran out of my second one, so traumatic. I actually sought some therapy after that happened, and it really opened like my mind and perspective to mental health, because I grew up in a culture where it was sort of like stigmatized and neglected. So it was really eye-opening as to what I could educate my community on. And then the last few kind of very obvious things, it's like, yes, it's a good work-life balance, tons of settings, and it is more of like wholly caring for a patient. Like you're doing medicine, you're doing like mental health, you're doing, sometimes you even do like their diet, or you do like, you help them with their fitness, you help them with their goals. So it is very like comprehensive care. So like I talked about this a little bit earlier, I sort of had a very positive experience with mental health and helped me through my MCAT anxiety. And it's just something that I thought really changed my perspective as to what I could bring back to my community. And then like I said, I was interested in psych, but I never really thought it was actually going to be my specialty. And then it was. So I really take that notion seriously, that as like a South Asian female, like a woman of color, I have to go back and teach my community what mental health is and why it's important. And I truly believe, like, when you're a woman and you get educated on something, you pass it down through generations. And so, for me, it's different because I'm in the mental health field, but in general, I feel like, when I know this information, I'm going to pass it down to the next generation, the next generations. And so every woman that I educate on mental health, that's going to pass through their generations. And it's really going to change what I think is sort of like the nuances of psychiatry and mental health, and why they're stigmatized. So there'll be more conversation over time. So that's my spiel on like my whole thing. This is a little bit about what actually psychiatry is. So I treat all of these things. I will tell you that the ones on top are my big ones. I do a lot of depression, not like simple depression usually goes to primary care, so it goes to their PCP, but like treatment-resistant depression or complex depression. I treat a lot of alcohol use disorder, anxiety, bipolar. I do personality disorders. A lot of what I do in the ED is like psychosis and agitation. A lot of what I do on consults is medical teams consult me in the hospital, and I figure out what medical conditions potentially are mimic psychiatric conditions and vice versa. I treat a lot of OCD because OCD is usually not something that PCPs can handle on their own. I do a lot of bipolar in my psychiatric hospital, and then a ton of substance use in my private clinic. So there's that. As you can see, there's not a huge list, but definitely diverse. So what is psychiatry? It's basically teaching people what mental health is, supporting them, and educating them. That's the biggest thing about psychiatry. And it's funny because that's actually why I got into it. So I fit right in with that notion of education. This is also kind of like why I love doing things like this, because it's just like passage of knowledge, and that's really what psychiatry is all about. And if you look here, people really just think that I prescribe meds, or we as psychiatrists are just like pill prescribers, but this is a list of all the therapies that I'm trained in as a resident, and it's a huge list. So I can do CBT, and I can't do it as trained as like a psychologist, but I do have like training hours and practice in all these types of therapies, breathing techniques, trauma therapy. I do like consultations for meds versus therapy versus both. I'm really interested in nutrition as medicine, and that's kind of what I'm studying for my last year. I'm going to be taking like a culinary, a nutrition class for psychiatry. That's like an elective at our program. Movement as medicine. There is also like yoga as psychiatry that people specialize in, and then dialectical behavioral therapy, which is a type of therapy for narcissism as well as borderline personality disorder. So all of those. I mentioned that it's a really a specialty where every day can look different, every month can look different, because like I said, I can pretty much work in all these settings, and I've done rotations in all of these, including several months in the ED, of course, inpatient, outpatient. I'm doing consult liaison right now. I have not done detox centers or rehabs. That's going to be the second half of my third year, but I've done ECT and I've done all child, geriatric, and adult psychiatry. So lots of stuff. And these are all like subspecialties too. So that's kind of exciting. I always talk about how psychiatry is one of those specialties where you have like terrible, terrible moments, awful, sickening, and then you have like very, very beautiful healing moments. And I'm going to walk through some of those healing moments. It's sort of like this very special thing when you get to help someone come out of depression and see who they are really as a person. That's one of my favorite things. Educating a family about someone's mental health diagnosis and getting them more aware, educating them around like the cultural aspects of it. Having a sick patient leave the hospital, it's one of my favorites, especially when very, very psychotic patients come in and then they leave, talking exactly in linear format and making sense again. And it's just so great. One of my particular favorites is teaching a family about bipolar disorder, one of our most stigmatized diagnoses that does require lifelong medication. So kind of teaching a family about how to like, work with their child, or how to help them through college and getting them settled. Of course, kind of plays in hand with breaking the stigma. Inspiring others to talk about their anxiety. Just because I'm open talking about it doesn't mean everybody else is, and that's completely okay. But it is quite empowering when you reach a point where you have really no reservation sharing it with others and not feeling anxiety about having anxiety. And that's really a beautiful thing that I think people need to reach, because anxiety is such a common thing, and it's normal in some sense. And so talking about it should also be normal. This one is kind of a special one that I'm still learning, because I'm doing trauma therapy training right now on Mondays. And being the first person to hear someone's trauma, very difficult what you share in those moments in the room. I was one of the first people that a woman told about her abuse, and I was one of the first people that this police officer told about his trauma on the field. And so it really is very special to help them through that. And then, of course, the last one where, we're still working to really understand addiction and fully really treat it, but being there for someone who's really lost everyone because of how bad their addiction is. And, I do see that in the ER and sometimes in the hospital too. And not to paint you guys this beautiful picture of psychiatry, although it is quite beautiful. I did want to show you guys the other side and things that are just heartbreaking. Very chronically sick patients, so baselines are quite low for a lot of patients who are schizophrenic or schizoaffective. Lack of funding for homeless people, really no rehab for people who aren't, fully insured, at least in Texas. Just like how limited beds are, how limited psychiatrists are, child psychiatrists, appointments, just like that whole thing. You have no power over their social status. You see very awful situations for children. Like I worked at the Family Abuse Center, like for women as well. Just sort of these situations where you really can't change the dynamic, and you're dealing with a shortage of providers. You have patients who are homeless and needing psychiatric care that don't really need psychiatric care, just need help with home, with shelter that get in the way, agitated patients. That's a big kind of scary one. And I always, I was always worried as like a very small woman. I'm like really petite. I'm like 5 feet. I was really worried that agitated patients would be something that I couldn't handle or that I would get hurt in the field. But really you get very good at keeping on guard and being alert, and you become an expert of like reading your environment. And then last but not least, it is incredibly emotionally fatiguing. Not as physically fatiguing as some of the other specialties, but just very emotionally draining at times. And so you have to have a good separation. With that said, I do love my specialty and I would never change it. I love it every single day. And I feel like I really made the right choice with what fit me. As we I do want to give you guys time to ask questions, but quick little patient case scenario for you guys. Quick thing, I'm just gonna ask one of these guys, how do they kind of respond to questions?
Well, YouTube is lagging currently, so I guess they will be responding to your questions afterwards, like maybe 10 seconds later.
Okay, sounds good.
So yeah,
thank you.
No
and so this is my presentation. So this is when I was an intern, one of my most interesting cases, but I had this 20-year-old male, and he had a history of just depression. He was on Prozac, and he came to an inpatient hospital after being found in one of the pools in Austin. And basically had broken into a home, stolen a popsicle, and was found to be eating it. And it was super bizarre. He reported that there was nothing wrong with the situation and he just wanted to go home. But he was in our high-risk security inpatient unit, and he was just sitting on bed looking chill as ever and telling me that there's nothing wrong at all. He denied really any problems. He kind of laughed at my questions. He's super distracted, kind of like not able to focus on one thing. He was like eating he was eating fries, and then he was walking around the room and just like all over the place and laughing at things that weren't even supposed to be comical. He tells me at the end of the interview that he is going to be doing a multi-billion-dollar deal between Apple and Amazon next week. And I was like, interesting. So this is kind of like the case presentation. What do we do next? So I'm kind of revealing the answers because I know there's a little bit of lag, but hopefully you guys were able to kind of think of what to do next while I was explaining the presentation. But which one of these would you guys think of doing first?
Well, for now, there is no reply, but would you ask more questions and clarify?
Yeah, absolutely. I like that. Ask more questions and kind of find out what really happened to make this person break into a house without clothes and steal popsicle. Sure, yeah, I definitely asked a lot more questions. One of the big things we want to do here is a drug screen, because this kind of behavior, sort of a nuanced thing, they don't have a history of it. It could potentially be multiple drugs that could be involved. The next big thing I would do is he's 20. So I need to make sure that I am working up labs to figure out if anything else is going on, because there are a few medical stuff that can mimic what he was experiencing. So that could be like thyroid problems. We kind of want to do like a full workup to make sure nothing else is going on with him. And then we want to get collateral. So collateral is basically a fancy way in psychiatry of calling a family member and asking them what's really going on. And so that makes our work twice in terms of talking. So usually we talk to the patient, we get an idea of what's going on, then we get collateral to see what the story on the other side is, because usually our patients aren't very good historians. So I did call his parents, and his parents tell me that he works for a startup that works with Apple and Amazon. So that was not that was the truth. But he's been acting really strange for about 2 months, and he lost his job where, he was working on this startup in San Fran, moved to Austin to be with his parents, just wasn't doing well, and no longer has a job in the tech company. And I was like, interesting. So there's not really a big trade going on. He's kind of lost his job, and he's been acting this way for a while now. And so what do I do next? So this guy is asking to leave. He's saying nothing is wrong. So the tough thing about psychiatry is sometimes forcing people to be in the hospital when we think that they're sicker than they realize they are. So a lot of psychiatry, we deal with something called filing. That's our legal way of making sure we can get a sick psych patient to stay in a psych hospital against their will. So it's basically a document that I can fill out and say, this person's wanting to leave against my medical recommendations, but they are not functioning the way they should be. They're going to be a threat to themselves, others, or deteriorate to a point where they can't take care of themselves. And those are my 3 reasons for filing on someone. So this guy didn't really meet that criteria, but because of how he broke into someone's house, he's potentially a danger to others. So we did file on him, and it did go through. So he was held at the hospital so we could figure out really what's going on with him and diagnose what's going on. I'm going to give you guys, I'm going to give you guys a few minutes to think about what might be going on. Okay, I'm gonna flip to the next slide. So these are some thoughts about what might be going on. So could be depression. He did say he has a history of it. Could be anxiety. It could be bipolar disorder. It could be schizophrenia. Other things that I left out on here, it could be drug use. His drug panel was negative. His labs came back completely normal. So there were no other medical concerns. His urine drug screen was negative, like I said, so not drugs. So, the other possibility could be ADHD. And so those are all the things that we were thinking at this point. I did have a med student with me in the room, and so we kind of went through this differential together. But I'm kind of going to reveal what was going on. So here we go. The diagnosis is bipolar. And I have this great sort of graphic that says what's going on. So he was distracted. He was grandiose. He thought he was going to do like $1 million deal, kind of thinking that he's like running those 2 companies when he really lost his job. Flight of ideas. So he'd kind of like go from one topic to the other. He would eat fries and then walk around, like I was saying. And the most important one, the one that we as psychiatrists are very good at assessing, is a sleep deficit. So when I talked to his parents told me that he's been acting this way for like a month or 2, but the biggest part of it has been that he has not been sleeping. In fact, he has not slept for a week, which really helps us use the DSM, which is our manual that we use to make diagnoses, kind of come up with our diagnosis, which is bipolar 1. And so this is a mnemonic for someone with mania, and which is what this guy was presenting with. So bipolar disorder can have two sides of the coin. It can include depression. It can include mania. So depression is when you're having the exact opposite of dig fast, and you're depressed, you're low energy, you're not interested in anything. And then mania is the opposite. You're not sleeping, you're super distracted, you're thinking you're top of the world, you're going from one topic to the other, you're kind of walking around everywhere, you're talking fast. And so there's 2 sides of that. When this guy was presenting with the manic side, but the reason it hadn't been kind of known that he had this is because the only symptom he'd had before was the depression. So that's what he was on. So we decided to treat him for bipolar disorder. And the treatment for bipolar disorder is a mood stabilizer. And there's several forms of mood stabilizers, but there's really one that's like what we call the gold standard of treatment, and that's lithium. And I'm sure you guys have heard of lithium, but basically it's our best drug for bipolar disorder, along with an antipsychotic, which we give when they're acutely manic. But once they kind of get through that episode and they've been okay for a while, we try to get them on what we call monotherapy of lithium, meaning they have bipolar disorder, but it's well controlled, both sides, depression and the manic symptoms, with just one medication. That would be monotherapy with lithium. And then we do have patients similar to this guy that have a really hard time accepting their diagnosis. They're so used to that high that comes from like running that fast and thinking that fast and being that fast and not sleeping and all that kind of stuff and getting a lot done, that they really get used to that high state, and being at normal level is really hard for them, and they stop taking their medication, or they're not able to tolerate lithium, or they just refuse to take it. And for those patients, we do something called an LAI, which stands for long acting injectable. As you guys can see, this is a little image that I've found of how to administer one of the long acting injectables, which I did do for him. So this guy became my clinic patient after he was discharged from the hospital, and he was with me for the next year until he moved to a different area. And I got to administer his injections every month because he was having a hard time really wanting to take the oral medication every day. And so as you guys can see, it's like, this is the way we do it. It's like a monthly maintenance dose. We give it in the shoulder, or we give it in the gluteal, and I administer them depending on how much strength they're needing to control their symptoms. And so the medical side of all this is sort of being able to dose this, understand the side effects that they're having from these, monitor their lithium level, monitor their thyroid, because lithium can alter your thyroid level. You have to get regular kidney checkup because, so I order labs to check kidney function every 6 months, because lithium can affect your kidneys in a negative way. And then with the antipsychotic, I have to do weight monitoring, lipid monitoring, which is basically monitoring cholesterol and triglycerides over time. And then I also have to monitor their A1C to make sure they're not developing diabetes from being on these medicines, which does happen to a few folks. And a lot of the medical side comes with using these drugs. Hence the big difference between the psychology part. So that's the treatment. A little bit about myself before I go and take questions, but I am thinking inpatient psychiatry. I love the very sick patients that we help to get back to their baseline. And I am thinking that I really want to do neuromodular stuff. So that would be stuff like ECT, which is something we use for treatment-resistant depression for very, very sick individuals, to help their brain kind of rewire. And it's really good for severe depression. And I have really enjoyed working with those patients. That's probably what I'm going to end up doing. That's pretty much everything. I'm gonna just, I'm just gonna leave it here, and I will wait for questions, or if one of you guys wants to tell me if I should use the YouTube channel to get the questions.
We can just read them out to you if that's fine.
Sure.
So the first question we have is, what is the most difficult situation you have faced in your residency?
Okay, yeah, that's a great question. So for me, I had this 1 month, it was towards the end of my intern year, where I worked with an attending that I didn't really get along with. I'm someone that really gets along with all of her colleagues. It's one of my priorities to make sure there's no conflicts in my work environment. But this particular attending, I just didn't feel like they respected my time. And they would ask to like round or meet at certain times, and they would never show up on time, never. And I would wait and sit and like wake up early, get there, get my work done, and be there on time, and I would never get the same respect. And it was, I had to be like, well, I'm a resident, like that's, this is kind of how it is. Like I can't say anything. Who am I to be like, oh my gosh, this like higher up superior person who's my attending is showing up late, at the meeting times that she's picking herself. And it would be like multiple times in the day that this would happen, and I wouldn't be able to find them. And it was kind of getting frustrating. And so eventually I kind of got the courage to speak up to my chiefs and to some of the evaluation that they do at the end of the year, where they ask you like if anything that didn't go well. And it turned out that a bunch of the other residents also had kind of strange experiences with this attending, and there was some other internal stuff going on. And so for me, like, it was just like, I'm glad I got the courage to speak up about something. And it's just hard when you're in a role where you're not equivalent to that person, because medicine is a hierarchy. And I work with really, really wonderful attendings who are just so helpful in my learning process, really prioritize my education and my training. And this was just like one exception. And so it was just like, I didn't let that bring me down. But I think the most important rule is like, speak up about how you feel, and don't kind of just let things slide by when they're not right.
What are some tips to perform well in the MCAT?
Okay, yeah, great question, because I definitely took it too many times not to be able to know this answer. I would say as many practice questions as you can possibly do, even if you've already done them. Even if you've done the whole bank, do the bank again. There's not enough practice questions you can't do. Like, and that's a double negative, but you spend as much time as it takes to do practice questions, and do not allow a bad score to bring you down. Like I said, my score was way below average, but the rest of my application truly showed my love for medicine, my love for helping people. And there's no way an admission committee can brush that aside when it's so clearly present on paper and in person. And so just remember that, like, do all the practice questions you can, prepare as much as you can, but it's not the end all be all.
And as a follow-up to this question, what do you think is the best study method for someone that struggles with test taking?
Yeah, I think the same answer. I would say do questions, but I would say this. After taking the MCAT 3 times, and then also taking 3 of the steps, like step 1, step 2, step 3, the one thing I've learned about anybody with difficulty with testing is make sure you're practicing stamina. These tests are meant to not just test your mind or test your knowledge. They're literally like testing your ability to withstand stress and see how long your mind can function. Because that's actually what happens in residency, especially like when you do your medicine months. They're testing to your stamina. And so make sure you're timing yourself and practicing. Make sure you're challenging yourself at home itself. Like, can you get through an entire practice exam the way you would get through it on that day? Are you taking the appropriate breaks? Are you not kind of like taking too long of a break? Because when you do, you think that you'll be fine on the real day, but if you simulate it, you'll be way better prepared.
How hard is medical school as compared to undergrad?
I would say it's easier. Maybe it's different for me. I would say it's easier because I spent most of my undergrad so like sort of like always feeling on edge that I wasn't going to get it. Like, I had to keep trying, and I had to get in. But with med school, you're already in. And it's just about like keeping up with everything. You're not like trying to get into med school. And residency is not the same as like trying to get into med school, because the match rate is incredibly high. You're going to most likely going to go into specialty of your choice without much of a struggle. I had a lot of disadvantages, even applying to residency, it's like I was a DO, so some people looked down upon that. I don't know, like cultural biases or even like size biases, that kind of stuff like played a role. And then, my step scores were good, but they weren't like incredible. So, like at the end of the day, you're still going to end up matching at one of your top choices. And so it's not as stressful. It's hard because you got to work hard, but it's not as it doesn't feel like you have to keep trying to get somewhere.
Among the different therapies that you provide, which one do you think is the hardest one?
I would say trauma therapy is the hardest. Not just like learning it, because I think it's trauma therapy is very book-based. It's a very book-based therapy. So you like follow a formulation to help them come out of that cycle of trauma. But I think performing it is very difficult because and this is, I don't know, some people don't feel comfortable kind of doing this as therapists or psychiatrists, but like you'll end up in situations where you're doing therapy with someone that did something that you are, for lack of better terms, like against. Like I did therapy with someone who was struggling with shame and guilt for being someone who had to torture people for the government. And you know, this person's feeling shame and guilt, and I'm listening to the story, and it's horrible what they've had to do and what they've had to go through. And I have to be that mirror. I don't think that he's a bad person. I think he was doing what the government assigned him to do, but he sees himself as a bad person, and he's filled with shame and guilt and can't keep going in his life. And so if I mirror, you know, how I feel in those, like when he's telling me those stories, it's sort of like I'm doing what I'm supposed to be doing. I have to show him that who he truly is not that trauma. And that's really hard to do because you're a mirror, especially when you're sitting in a room together and talking about things like torture. So I would say trauma therapy. I don't think I'm going to be like a trauma specialist or anything, but I think people who are incredible.
Did your field exceed your expectations of what you had initially?
Interesting question. I think so. I think I loved psychiatry for what it was, but when I like became a psychiatrist, when it became my profession, I realized how diverse it was, and I think that made me, that my expectations were just like, what, like this is even more than what I thought I was going to get. I had no idea that you could practice in that many settings, or how different every day can look, or how many opportunities I would have. So I think in that sense, it did exceed my expectations.
And as a follow-up, if you could change anything about your profession, what would it be?
I would say if I could change anything about it, I would really hope that we could sort of like use our resources better. So I don't know if you guys, there was like this show on Netflix with Hassan Minaj, and he had this episode of like mental health where he literally compared psychiatry and mental health to like all these doors that get shut on you, because finding a doctor in psychiatry, or even a therapist or a psychologist, is like a maze. You call one place, you call the other place, like they don't have insurance, they take this insurance, they're private, they're cash pay. It's a mess. It's a mess. And depending on what state you're in, people who really need help don't have help. People who don't need help, they have abundant options because they're all cash pay and they can afford it. And it's just, it's not that anybody doesn't need help, but it's more like can we fill those spaces where people are not getting help to sort of like equalize it a bit. But the idea is that, you know, we as psychiatrists are like going towards cash pay, which is fair because we're going to make more money that way because we can't bill that way with the medical billing system right now. And so I can see that that's the appeal, but then it's going to leave all these spots where people who don't have insurance but can't pay $300 for an appointment but really need the help, they don't have like a space. So I think if we could open those doors and equalize things a bit, that would be great.
So similar to how we see in psychology, is there more clinical research being done in this field?
Mm-hmm. Absolutely. There's a lot of research being done. There's a bunch of new stuff coming out. There's a new neuromodulation coming out too, and they're working on using sort of like other machine-based, biological-based treatments to treat depression as well. And we're figuring out more stuff about personality disorders and In terms of like meds, all of our meds are pretty new and more are coming out. So I would say there's definitely more, like psychiatry is going to look way different 10 years from now than it does today. And I think that's very unique about that, because I can't say that about any of the other specialties. It's going to be like a whole different field in 10 years.
And I believe the last question would be, how do psychiatrists deal with their own mental health problems?
Yeah, so I think that's really important to talk about. And, you know, wellness is a big part of the place that I'm from. My residency and my program, so good about that. I can't say enough good things about my program, but that would definitely be the big one. Is they do not overwork us. They focus on our growth and training rather than like making us like just body the work. And I think that's a big part of wellness and keeping your mental health better, but also just being open to being in therapy yourself. I did therapy all through my intern year, just to adjust to the new environment. I actually did, like my partner and I matched into different cities and different programs. So we became long distance with the match. And that was something I was like, getting accustomed to in the new city and not knowing anyone and starting this huge stressful thing. So I did therapy through my whole intern year, and that was really helpful. But in terms of like daily kind of like debriefing, so as residents, we get 1 hour a week to talk to a supervisor that's assigned for us for all 4 years. And we talk about anything that, you know, we heard that was traumatic throughout the week, or any case that we really feel like we don't know what we're doing with, or anyone that we feel like really needs more help, one of our patients, or anything that happened to you throughout your week that was difficult with your patients or conflict. So that hour of supervision, which we call therapy supervision, really helps. And the fact that it's there all 4 years for us every single week, it's just really great. But that's a way most programs do it. And then once you're like out in the field, they have like monthly groups that allow you to debrief on patients or talk about traumatic cases and stuff like that.
Thank you, Dr. Natasha, for joining us today and teaching us about psychiatry. It was a wonderful presentation. For those watching this, a link to the quiz will be posted on our link tree found in the Instagram bio and has also been posted in the chat box. Our Instagram ID is way_organization, so please make sure you have a look at that. And within this week, we'll also be emailing you your certificates. Thank you once again.
Okay, thanks for having me, guys. And I would just like to say that, you know, as a woman empowering other women, happy Women's Physicians Week to you guys. And thanks for having me on here. If you guys ever have any questions, you can follow me on Instagram. It's dr.psychandstyles. And these guys can have that for you through the chat or through their message portal, and you guys can follow me on there and message me with any questions. I love meeting students. I love meeting new people. So let me know if you have questions about psychiatry, medicine, anything. And it was really